Hello, everyone. Today we'll discuss prioritization in fluid, electrolyte, and acid-base balance. You can follow along in your outline. We'll begin by talking about how to assess fluid balance and identify early red flags that require immediate nursing action. Now let's talk about how we assess fluid balance and recognize early red flags. Normally, neck veins are distended when a patient is lying flat and they flatten when sitting up. That's a normal finding. But if those neck veins remain distended, even when the patient is upright, or if you notice swelling, lung crackles, or a bounding pulse, those are signs of excess fluid volume. This means the body has more fluid than it can handle, and the heart is working under strain. If you hear bilateral moist crackles, that tells you the alveoli are full of fluid and gas exchange is impaired. That's a critical finding. The priority action is to raise the head of the bed, apply oxygen if needed, and give intravenous furosemide as ordered. Furosemide helps mobilize and remove that fluid quickly. Now, let's talk about cardiac clues. When you see ST segment depression, inverted T waves, or U waves on the ECG, those are hallmarks of hypokalemia. Low potassium makes the heart's electrical system unstable and can cause heart block or dysrhythmias. Always check the potassium level right away, begin replacement therapy as prescribed, and place the patient on continuous cardiac monitoring. If potassium is elevated above 5, that's hyperkalemia, another dangerous imbalance that can cause life-threatening ventricular arrhythmias. Give Kayexalate to remove potassium through the gastrointestinal tract and hold potassium-sparing medications like spironolactone. For sodium, think about water balance. In conditions such as SIADH, water retention causes a relative sodium deficit. The cells swell, and the patient may show confusion or even seizures. These patients require close monitoring and fluid restriction. Now for calcium. A positive Schwastek sign, when the facial muscles twitch after tapping just below the ear, means hypocalcemia. This signals increased neuromuscular irritability. Patients may experience tingling, spasms, or tetany. Check calcium levels, institute seizure precautions, and report any abnormal findings promptly. If a patient has generalized muscle weakness along with low phosphate, that's hypophosphatemia. Remember, phosphate is necessary for energy production through ATP. Without enough ATP, the muscles, including the heart, can become weak. Severe cases can lead to rhabdomyolysis, or muscle breakdown. Replace phosphate carefully and monitor muscle strength. Finally, if magnesium levels are extremely low, below 1, the patient is at risk for ventricular dysrhythmias and seizures. These patients need continuous telemetry and intravenous magnesium replacement given slowly under close observation. When a client is tachypneic, anxious, or lightheaded, they're likely hyperventilating, which blows off too much CO2. This leads to respiratory alkalosis. The nursing priority is to help them calm their breathing, and if ordered, have them breathe into a paper bag to retain CO2. Next, prolonged vomiting or nasogastric suction causes a loss of stomach acid, leading to metabolic alkalosis. You'll want to monitor potassium levels, administer antiemetics as prescribed, and adjust suction settings to prevent further acid loss. Finally, clients with chronic kidney or lung disease, especially older adults, are at high risk for acid-base imbalance. These clients need frequent ABG and electrolyte monitoring to catch problems early and keep their levels stable. Now let's discuss the key nursing interventions and clinical actions for each of these problems. For fluid overload, raise the head of the bed, provide oxygen if needed, and administer IV furosemide. Limit sodium and fluid intake according to the provider's order. For dehydration or hypovolemia, restore intravascular volume with isotonic fluids such as normal saline. Avoid using D5W in shock because the dextrose is metabolized quickly, leaving a hypotonic solution that can worsen fluid shifts. For hypokalemia, replace potassium either orally or intravenously, but never as a push. Always use a pump and continuous cardiac monitoring. For hypocalcemia, give calcium gluconate and encourage calcium-rich foods such as dairy products, seafood, nuts, broccoli, and spinach. For hypophosphatemia, administer phosphate supplements and monitor muscle strength and urine output. For hypomagnesemia, replace magnesium sulfate intravenously and monitor reflexes for improvement. When respiratory acidosis develops because carbon dioxide builds up, as in COPD or slow respirations, increase the ventilator rate or encourage deep breathing to blow off excess CO2. For respiratory alkalosis from hyperventilation, help the patient slow their breathing. Calming reassurance or rebreathing techniques may help. If metabolic alkalosis occurs from vomiting or NG suctioning, stop unnecessary suctioning, correct the fluid and electrolyte loss, and address the cause. And remember that older adults with chronic kidney or lung disease are at higher risk for all acid-base problems, so monitor them closely. Now let's review how we teach patients and reinforce learning about fluid and electrolyte management. UAPs can reinforce a plan once the RN develops it. Encourage oral fluid intake only after the nurse has determined the goal. When teaching about oral care for patients on fluid restriction, remind them to use alcohol-free mouthwash to avoid drying. For patients taking diuretics, teach them to eat foods rich in potassium, such as bananas, oranges, potatoes, and spinach. Patients with low calcium should eat more dairy products, seafood, nuts, broccoli, and leafy greens. Teach patients taking hydrochlorothiazide, or HCTZ, to take it in the morning to prevent nighttime urination. Emphasize the need for potassium-rich foods, daily weights, and prompt reporting of swelling or weight gain. Finally, older adults who use antacids occasionally are fine, but excessive use can cause metabolic alkalosis. Reinforce moderation and symptom monitoring. When caring for clients with diabetic ketoacidosis or COPD, close monitoring is essential. These patients require frequent lab checks, especially ABGs, glucose, and electrolytes, and ongoing therapy adjustments by the nurse to keep acid-base balance stable. Changes in respiratory rate, level of consciousness, or oxygen needs can signal that their condition is shifting, so early recognition is key. Hyperventilation syndrome often happens with anxiety or panic attacks when the client breathes too fast and blows off too much CO2. The nursing focus is to help them slow their breathing, provide calm reassurance, and if needed, have them breathe into cupped hands to rebalance their CO2 levels. The goal is to calm both their mind and their breathing pattern. Now let's talk about how to delegate safely and supervise effectively. Match the task to the level of training and patient stability. Unlicensed assistive personnel can encourage fluids once the RN has set the plan, perform oral care, take vital signs, and measure intake and output. They cannot start IVs, assess patients, interpret ECGs, or perform fingerstick glucose checks unless their role description allows it. LPNs can provide routine care, give certain oral medications, and monitor stable patients, but they do not interpret lab results or care for unstable clients. RNs create and evaluate the plan of care, teach, interpret data, administer IV therapy, and manage unstable or newly admitted patients, especially those with acid-base imbalances or critical potassium shifts. Now let's review the safety and prioritization patterns that the NCLEX loves to test. When you hear crackles and see shortness of breath, treat airway and breathing first. Apply oxygen and give furosemide. If you see ECG changes suggesting a potassium problem, check the level and take immediate action. If a patient shows signs of neuromuscular irritability such as Schwostek or Trousseau signs, check calcium levels, start seizure precautions, and report it right away. When a patient has vomiting or NG suction, anticipate metabolic alkalosis and monitor electrolytes. Older adults with kidney or lung disease are high risk for acid-base imbalance and need frequent monitoring. And in hypovolemic shock, the only correct first choice for fluid replacement is normal saline. Now let's review medication and therapy pearls to reinforce safe practice. Furosemide should be taken in the morning. Monitor blood pressure, potassium, and daily weight. Spironolactone is a potassium-sparing diuretic, so teach patients to avoid potassium supplements and salt substitutes. Kayexalate removes potassium through the GI tract. Loose stools are expected, but dehydration must be watched for. Hydrochlorothiazide, or HCTZ, should be taken early in the day. Teach patients to eat potassium-rich foods and report swelling or weight changes. Antacids used excessively can cause metabolic alkalosis, so instruct patients to use them only as directed. And remember, for hypovolemia and shock, the isotonic fluid of choice is normal saline, not D5W. Now let's quickly review arterial blood gas patterns so you can connect lab results to patient care. If pH is low and CO2 is high, that's respiratory acidosis. Think hypoventilation or COPD. If pH is high and CO2 is low, that's respiratory alkalosis. Think hyperventilation. If pH is low and bicarbonate is low, that's metabolic acidosis, seen in diabetic ketoacidosis or renal failure. If pH is high and bicarbonate is high, that's metabolic alkalosis, seen in vomiting or suctioning. These relationships help you identify the problem source, whether it's the lungs or the kidneys, and guide your next action. Now let's summarize the top 10 NCLEX never miss points for this topic. First, crackles mean pulmonary edema. Give oxygen and furosemide right away. Second, ECG changes linked to potassium imbalance always require rapid assessment and correction. Third, hyperkalemia plus spironolactone is a dangerous combination. Hold the medication and notify the provider. Fourth, a positive Schwastek sign signals hypocalcemia. Report immediately. Fifth, magnesium levels below 1 are life-threatening. Prepare for dysrhythmias and give IV magnesium. Sixth, vomiting or NG suction causes metabolic alkalosis. Correct fluids and electrolytes. Seventh, a decreased respiratory rate signals respiratory acidosis. Stimulate breathing and call for help. Eighth, older adults with chronic kidney or lung disease have the highest risk for acid-base imbalance. Ninth, teach patients taking HCTZ to take it in the morning, increase potassium intake, and report any edema. And 10th, in hypovolemic shock, the only fluid that restores intravascular volume is normal saline. Now let's bring it all together. Fluid and electrolyte balance is about connecting subtle clues to the bigger picture. When potassium changes, the heart rhythm changes. When calcium drops, nerves misfire. When the lungs slow down, acid builds up. The NCLEX isn't testing if you can memorize numbers. It's testing whether you can act on the first sign of trouble. So when in doubt, assess your patient, protect the airway, restore circulation, and delegate safely. If you keep these priorities in mind, you'll handle any fluid, electrolyte, or acid-base imbalance with skill and confidence. If this helped you master another concept, hit like, share it with your classmates, and subscribe for the next Dr. Atkinson lesson.